Welcome, everybody, and thanks for joining us again. We're quite excited for the presentation tonight by Dr. Devon Christie. I'll do some brief introductions and cover some housekeeping points first. Then I'll hand it over to Dr. Christie. I'm Rob Comey, the psychiatry lead for the project. I'm joining you from Vancouver, where I live on the unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations. Tonight's presentation is the fifth of 7 in our virtual series on psychedelics and complementary techniques. The series was created by our fearless leader, Ellie Molnar, who is the project manager. Our GP lead is Dr. Jenna Creaser, and Jenna is going to lead tonight's Q&A session. Thank you so much, Ellie and Jenna, for doing all the heavy lifting and letting me tag along. I appreciate it. Let's quickly look at the agenda for tonight. First, Dr. Christie will present on psychotherapy and psychedelic medicines greater than the sum of their parts. Please write down any questions that come up. You'll have a chance to pose those questions, or I should say post them in the chat box after the presentation and during the question and answer session. Immediately after the presentation, we'll move to breakout rooms to discuss the presentation and to meet each other. And next, Dr. Creaser will host the Q&A session with Dr. Christie, who will answer your questions. And we'll aim to wrap things up at about 8:30 tonight. Please note that the session is recorded so that others can enjoy it later. The breakout rooms, however, aren't recorded. So we do not record the content in the breakout rooms. Attendance is recorded for CME credits. So you need to do one of 2 things. Either identify yourself on Zoom using your full name. Alternatively, you can fill out the attendance survey. There's a link for that will be provided in the chat box as well. Please also complete the mid-evaluation survey. The link to that will also be posted in the chat box. And that just gives us feedback on what's gone well, what you'd like to see, what you'd like to see less of, and so forth. So thank you for that. So let's get into the good stuff. I'm going to introduce Dr. Christie. She is a clinical instructor with the Department of Medicine, UBC Department of Medicine, and has a focused practice in chronic pain and trauma. She is also a registered clinical counselor emphasizing relational somatic therapy. She's a certified mindfulness-based stress reduction teacher and an interpersonal mindfulness teacher. She is trained to deliver both MDMA-assisted therapy for PTSD through MAPS USA and ketamine-assisted psychotherapy, and has been certified with the Institute of Functional Medicine. She is passionate about educating future psychedelic therapists on trauma-informed relational somatic skills, and is a co-founder and lead trainer with the Psychedelic Institute. She also teaches for the California Institute of Integral Studies in the certificate program in psychedelic therapy and research, as well as the Integrative Psychiatry Institute certificate program in psychedelic assisted therapy and the ONCA Foundational Psychedelic Therapy program. She is currently principal investigator and study therapist for a Canadian MAPS-sponsored open-label compassionate access study investigating MDMA-assisted therapy for PTSD, a parallel qualitative study, and co-investigator on a study investigating MDMA-assisted therapy for fibromyalgia. Devon is a recognized speaker and expert on the potential for incorporating psychedelic-assisted therapies in an improved healthcare model for the future, and is the Medical and Therapeutic Services Director with Numinous Wellness. So we're very, very excited to have Devon, and please give her a warm virtual welcome.
Thanks, Rob. And thanks to Jenna, Eleonora, and everyone else supporting. And thanks for everybody who's tuning in on a Wednesday night. I'm just going to go ahead and pull my presentation up here. And just make sure I'm actually presenting. And okay, here we go. So it's a pleasure to be here, and I'm excited about the topic today, which is this psychotherapy and psychedelic medicines greater than the sum of their parts. And I came up with that title because, you know, I think it's really important, especially with a physician audience, to present how psychedelic medicines are quite unique and really deserve unique consideration as to how they work. And as you'll learn in the presentation this evening, I'll be speaking a lot about how psychedelics are really very much an adjunct to a interchange process for a person that is supported by psychotherapy or specific factors in the context of the intervention. So very much different than the way we might think of other drugs that we commonly prescribe. Okay, so I am also here on the traditional ancestral lands of the Musqueam, Squamish, and Tsleil-Waututh nations, and privileged to be here as an uninvited settler. I also want to honor that psychedelic assisted psychotherapy was developed in the context of colonialism and the systematic oppression of Indigenous peoples, and has also historically disadvantaged Black, Indigenous, and people of color, as have research offerings been developed primarily by white cisgendered researchers working predominantly with white cisgendered research participants, heterosexual research participants. And this leaves a lot of gaps in the field. And so we're working together to redress this. And I also want to just acknowledge my own intersectionality as a white cisgendered female, and that my own background and privilege may certainly leave blind spots in the information I'm presenting to you. So I'm always very open ears for feedback and continued learning from anyone that may identify such gaps and bring that to my attention. I'm very grateful. Otherwise, really not much to disclose. I have no financial conflicts of interest. I am an advisory board member with MAPS Canada. And as mentioned, I founded a psychedelic training organization in addition to working with numerous other organizations in psychedelic training. So we're going to talk tonight about a paradigm shift in mental health care with pharmaceutical as adjunct. A little bit on the historical context, and as well going further into what this extra pharmacological model of using psychedelic medicines is about. We'll review some of the current applications and modalities that are being investigated in the research right now, as well as some applications outside of a research context, and then talk about some of the proposed psychobiological mechanisms and understanding really how these interventions might be working. I'll review some important therapist competencies in the delivery of psychedelic assisted psychotherapy, and then we'll be able to muse a little bit about the future and what the future might hold. So pharmacotherapy is currently the primary treatment within the medical model for mental health conditions in Canada. Psychotherapy is typically not funded in the provincially administered healthcare models, and most people are presenting to their primary care physicians and typically offered pharmacotherapy when they're presenting with mental health concerns. And however, we do know, there has been research comparing head-to-head pharmacotherapy and psychotherapy. I'm citing an example here with major depressive disorder, which is the most common psychopathology or presenting mental illness in primary care. And what we have seen from numerous studies and systematic reviews is that while both can be effective, they both have limitations. Pharmacotherapy is typically effective for the short term, but often when stopped, the efficacy doesn't persist. Whereas psychotherapy can certainly have long-term advantages. It can result in improvements of quality of life, more than just symptom reduction in comparison to pharmacotherapy. It's often better tolerated, better accepted, with less side effects than pharmacotherapy. But really the consensus right now is that both have limitations, and we really do need to be looking at other models and other innovations on kind of these two primary ways that mental illness is addressed currently in our healthcare system. I mean, I would argue that psychotherapy ought to be adapted into our healthcare system with universal coverage. There's a lot of epidemiological data that would support that on the population level in terms of cost savings to our healthcare system. And I do hope that we move forward to parity between physical and mental health care in our future healthcare system, especially with the global pandemic and obviously the impact and the rising alarming rates of mental health conditions. But then beyond that, we need to be looking for other interventions, and perhaps interventions that might be more rapid acting, more efficacious. So interestingly, it really is kind of thought to be the gold standard to combine psychotherapy with pharmacotherapy to sort of synergize and combine the benefits of both where that's possible, where people can afford that or have access to that. When combined sequentially, there was this a systematic review that showed that there's increased relapse prevention. This is sort of a brief pharmacological intervention followed by psychotherapy, which was presented as a conceptual shift in a 2021 JAMA paper in how we approach mental illness. And so this is kind of like paradigm shifting, like how might we combine both pharmacological and psychotherapeutic interventions, harness the biological effects of pharmacotherapy, but also the learning and behavior change and support that can come through psychotherapy. This Greenway et al. Paper, also 2021, outlines how both pharmacotherapy and psychotherapy act biologically and psychologically, both. So pharmacotherapy having psychological impacts and psychotherapy having biological impacts, including changes in gene transcription, so epigenetic modifications, changes in neuroplasticity and wiring of the brain, and changes, architectural changes that can translate into a behavioral change and other outcomes. So both are working, and this is when we're still talking about conventional treatments. So then the rest of our conversation tonight is going to be about psychedelic assisted psychotherapy, which is kind of taking this shifting paradigm to the next stage, where there's this intentional combination of a very powerful psychoactive medication in the context of a psychotherapeutic protocol that's carefully constructed to maximize safety, minimize harm, and maximize benefit. So break on through to a true paradigm shift. A couple of these interventions have been named breakthrough therapies by the US FDA recently. I list esketamine here in 2016. It's not a psychedelic assisted psychotherapy. It's an intranasal application of the S enantiomer of generic ketamine, sort of purified, and with an indication for depression. that it does fall into the class. Ketamine itself and esketamine, its enantiomers, fall into the class of psychedelics. And arguably, there are other models with the use of esketamine or ketamine in general, combined with psychotherapy or sequential combination that could even be more beneficial, we don't know, than esketamine alone. The other two interventions deemed breakthrough therapies are MDMA-assisted psychotherapy in 2017, and then psilocybin-assisted psychotherapy in 2019. And to get this designation, the intervention has to show benefit above that of available therapies for life-threatening illnesses. So it needs to be a true breakthrough, a new innovation, better than anything else out there in treating something life-threatening. And these three things are sort of the most big advances that we've seen in psychiatry and mental health care in the last 5-10 years. So all three of these substances are classified as psychedelics and can produce powerful temporary alterations in consciousness. There are different classes of psychedelics, however. So to briefly review the classes of psychedelics, classical psychedelics are LSD, psilocybin, DMT, and mescaline. They're acting at 5-HT2A receptors. They have, similar states that are classified or typified, often ego dissolution, unitive states at high doses. Whereas MDMA and other entactogens, or there's a T missing in entactogens on my slide, or also known as empathogens, are mixed monoamine reuptake inhibitors. So there's dopamine, serotonin, norepinephrine that's impacted. And there's others within this class as well. MDMA so far being the most studied and the furthest along towards FDA approval in combination with psychotherapy for PTSD. Then we have other types of psychedelics, the dissociatives. So ketamine is one of those, others dextromethorphan, nitrous oxide. They're working on NMDA receptors. And then we have others that are known as atypical psychedelics, like Salvia divinorum, ibogaine. These come from plant medicines, anticholinergic, sort of atropine and datura, as well as cannabis. Cannabis is a very common one. It's also considered an atypical psychedelic. So they have various different mechanisms of action. So to move into then considering this pharmaceutical as adjunct, psychedelic assisted psychotherapy, again, is this intentional use of a psychedelic medication within a specific protocol of psychotherapy designed to promote safety and maximize healing benefit. So this little table here shows how conventional pharmacotherapy in psychiatry and mental health is typically geared towards symptom suppression, usually daily use, can often take several weeks to months for benefit, is often a primary treatment, and doesn't really come with any contextual requirements other than perhaps in some cases avoiding alcohol or other things. Whereas psychedelic adjuncts are very unique, engendering non-ordinary states of consciousness. They could be thought of as expressive therapy. So rather than attempting to suppress symptoms, a psychedelic is given intentionally in a sense that it can actually surface a lot of material and content that can then be processed within a psychotherapeutic frame, and very often with curative intent when we're seeing the promising results in the recent literature, and especially for the breakthrough therapies mentioned. Their use is limited in the research. Usually 3 occasions is often the most times a person actually takes the substance. They do have immediate benefits in terms of their immediate or acute action, which is engendering this non-ordinary state that is creating some of that context for the healing process for an individual. And also we've seen in the research that there's also quite immediate benefits in terms of essentially being a brief intervention, MDMA assisted therapy, for example, happening over an average of 3 to 6 months to get to an endpoint of what we've seen with MDMA and PTSD, 67% remission of severe post-traumatic stress disorder after that period. That is then robust from the phase 2 data at 12 months follow-up with no further intervention after 3 doses of MDMA in this context. So the MDMA or these other medications, psilocybin, for example, in depression, they're really acting as an adjunct or catalyst to a therapeutic process of change for the individual. And they're absolutely fundamentally dependent on the context in which they're given. So we're going to talk a bit more about that. But first, some historical context. Ayahuasca, peyote, psilocybin mushrooms, and many other plant-based psychedelic substances have been used by humans as a sacrament and medicine in very specialized contexts since time immemorial. And it's important to acknowledge that a lot of the care and attention to crafting a set and setting, which we'll talk about more, or the context of the therapeutic use of psychedelics was actually derived from awareness of the wisdom and the many generations of passed along traditions in holding a ceremonial container with specific things to actually create a safe space and a conducive space for healing or for gathering community together for communion or sacred purposes. So I wanted to just provide an example of what this might look like. So with MDMA therapy, which you have heard about, so some of you, this might be review from Dr. Ingrid Pacey's talk. People come in, there's medical screening, ensuring that there aren't any contraindications from a medical perspective or a psychological perspective to the treatment. And then you can see here, there are 3 preparatory sessions with the therapy team. It's a co-therapy model, so 2 therapists. Doesn't matter the gender of the therapist. It used to be 1 male, 1 female. Now it doesn't matter. And then the MDMA session, which lasts a whole day, 8 hours, sometimes longer, followed by 3 integration sessions, 90 minutes each, followed again by an MDMA therapy session, then 3 integration sessions, MDMA therapy session. That one's yellow because in some of the research protocols, it was optional to have a integration sessions and closing. So that's kind of the container. So I want to talk now about this extra pharmacological model. So what's going into, what are the factors that are working with this psychedelic adjunct to create these outcomes? So this has been called set and setting, has also been referred to in the literature as context. Set and setting was, it's actually sort of debatable who first coined that term, but it certainly showed up in 1963, sort of before the era of the criminalization of these substances and the sort of 30, 40-year lockdown on any further research progression until the more recent Renaissance. So this little diagram is from Cartart-Harris 2018 paper, where they're talking about how individual traits, so intrinsic traits to the person, plus the pre-state that's created or the set or mindset through the preparation that happens with the therapy team, with the screening and all of the pre-psychedelic preparation, then go into the state where there's a dose and there's an environment. So effects are going to be dose dependent, as well as dependent on environmental factors, which I'm going to review more. And then from there, we see long-term outcomes. Environment is also influencing pre-state and long-term outcomes too. So when people exit a protocol or a study, if they're going back into a socially unstable environment or homelessness, as had occurred for some participants in the MDMA trials early on, those people tended to not do as well. So those social supports and other conditions actually pre and post also make a difference as well. So when we're talking about context or set and setting, the set, as I mentioned, is the mindset. So how one is prepared. This has to do with intention setting, which actually has been shown. There was a recent systematic review by Ade et al. That really went through and showed that a clear intention setting definitely has an impact on positive outcomes, on the possibility of having a mystical type experience. Spiritual intentions going in will predispose one to a mystical type experience. And we also know that mystical type experiences, these unitive experiences, feeling connected to everything, are predictive of positive outcomes with relation to the indication, be that depression, end of life anxiety. So that's part of preparation, is helping someone to clarify their intention for themselves. Factors around mindfulness as a trait and also as a state. So it can be, people will have varying levels of trait mindfulness based on their history, but then mindful approaches as part of preparation, being in the present moment, being open to experience, and other aspects that we see in the psychological flexibility model, which informs acceptance and commitment therapy, openness to experience, approaching experience rather than experiential avoidance. This can all be part of prep in terms of helping to guide a person in the attitudes and awarenesses they will bring into the psychedelic experience. It's also very important to enhance trust. So when people have a positive mood, positive mental state, a state of surrender, which we'll see in the next slide, which is very much supported by things that can enhance trust. So trust in the therapist, trust in the whole medical process and one's safety, is also very much important for outcomes. So, and then the setting has to do more with it, more external factors like the aesthetic of the room. There's been some research into healing environments, which even with the absence of a psychedelic can make a difference to one's emotional state, one's state of arousal in their nervous system, feeling of safety. And this is being applied in healthcare environments, even aside from psychedelic context. But one can appreciate that in a psychedelic context, when one's state of consciousness is altered and quite open, these factors have even more importance. So things like soft colors, round edges, nothing too intrusive, really thinking about the room layout, placement of furniture, objects in the room, maybe wanting to attend to not place objects that might be culturally inappropriate for some people, and trying to really think about how to keep things neutral but evocative of positive experience. So often biophilia, plants, nature-based themes can be supportive, as well as the therapeutic presence of the practitioners. That's a big part of the setting. There's something called the intersubjective field, where me and another in a co-therapy model are each of our subjectivity is meeting one another in sort of the relational field. And there's all the aspects of communication happening beyond our spoken words that are being registered and picked up in our nervous systems mutually, especially for the person in the psychedelic state. A lot of those nonverbal cues and other things that may go unregistered in ordinary states of consciousness might be even more sensitive. So therefore, the therapeutic presence and awareness and embodied self-awareness of the therapist is very much important to the context. So this is from the Carhart-Harris paper, actually the one I was mentioning earlier, which just shows that increased readiness, increased intentionality, a positive therapeutic setting, and higher drug doses are all positively associated with peak or mystical type experiences and greater increases in well-being at long-term outcomes, whereas decreased sense of readiness, decreased intentionality, and lower trust increase the propensity to challenging experiences with more muted increases in well-being, but well-being nonetheless. This is from that Ade paper, more recently published, where you can see here that absorption and surrender and acceptance on the sort of the top left are associated with mystical type effects, peak experiences. And when those are low, we see more adverse effects. And conversely, preoccupation, apprehension, confusion are associated with lower mystical type effects and higher adverse effects. So it's just a nice little diagram here. This is a composite of many different studies. And some of these things are like trait openness, personality trait openness, for example. At any given moment, you or I or anyone has certain personality traits that were previously thought to be sort of lifelong and not really changeable, but that's been proven wrong, especially through the psychedelic research, which is showing that these traits are actually amenable to long-term change, with long-term follow-up showing increased trait openness, for example, in individuals. And some of these things like priming someone for more absorption in their experience through mindfulness practices, or surrender through trust enhancement, and acceptance through, providing education, can all be done as part of the preparation. So these are modifiable in many ways as well. So to turn to current applications, the MDMA for PTSD manualized therapy model is called inner-directed therapy. And within that manualized approach, there's room for other approaches, and certain approaches are actually considered to be quite supportive to the change process. One of those is internal family systems, which is considered an evidence-based psychotherapeutic modality. There's a paper on using IFS specifically in psychedelic integration referenced here, that's used and mentioned in the training of the MDMA therapists as a very supportive complementary modality, as well as somatic approaches. So those are approaches that inherently have an understanding of the nervous system and the psychobiology of our stress response and survival systems, as well as interpersonal neurobiology and how one nervous system can help to regulate another nervous system, or vice versa, states of resonance, coherence, attunement, and very much rooted in present moment awareness of one's embodied experience. These are also felt to be very conducive and supportive within the context of MDMA inner-directed therapy. There was a study published recently on cognitive behavioral conjoint therapy, which took the manualized MDMA therapy and framed it within this sort of couples CBT approach, where couples went through. This one was not placebo controlled. It was sort of a proof of concept study, but one person in the couple had PTSD, the other was their caregiver or support person, but both were impacted by the PTSD of the one person in the couple, and outcomes were positive for both, with this sort of frame and addition of conjoint cognitive behavioral therapy. Emotion-focused therapy is another modality. My colleague, Dr. Adele France, who's done a lot of work in this field, teaches emotion-focused therapy, has written a book on it. She's writing up a paper right now on the application of EFT in ketamine-assisted psychotherapy to treat major depression. It's also a process-oriented therapy. So all of these therapies really that I'm talking about are considered process-based. So they tend to be present moment-oriented. They tend to focus on process and relationship to one's experience, rather than necessarily changing thought patterns. That happens almost as an epiphenomenon of this different way of attending and relating to one's experience, and being encouraged to use processes that help to move emotion, to work with sensation in the body and other things in real time. The psychological flexibility model informs both acceptance and commitment therapy, and a modification of that that's specific to psychedelic therapy that was developed by Rosalind Watts at Imperial College London for psilocybin therapy for depression, called the ACE model, Accept, Connect, Embody, that both are rooted in the psychological flexibility model and are showing promising applications for the treatment of depression with psilocybin. Slow Shower at Yale University was using a very clean ACT model as the frame. But it's important to understand that when people are in the altered state of consciousness across the board, when we're talking about ACE, acceptance and commitment, there's really this kind of stepping back and holding space for the person's process. And across many protocols, and also within Indigenous traditions and wisdom traditions that inform these practices, is this orientation that is brought up in the preparatory phase towards innate healing intelligence, so that there's an inner healer or some sort of innate healing intelligence in the person, the participant, in all of us really, that we can trust will be enhanced by the addition of the psychedelic medicine as an adjunct, and to really allow that to guide the psychedelic process itself. And then these frames of acceptance and commitment or other approaches are really there often in pre and post, in prep and integration, and also a little bit in sort of the therapeutic approach when there is engagement, sort of up past the peak and as the effects of the psychedelic are wearing off or leading in. Motivational enhancement therapy and mindfulness-based relapse prevention are both being researched in applications for substance use disorder with ketamine and sort of immediate post-infusion ketamine, motivational enhancement, for example, or interspersed ketamine infusions in a mindfulness-based relapse prevention program, which is a evidence-based group program for relapse prevention. There's another model my colleague Saj Ravji developed called psychedelic somatic interactional psychotherapy that he's written up in the Journal of Psychedelic Psychiatry that is really leaning into these somatic approaches and psychobiological understanding, and really understanding that in these altered states of consciousness, we're accessing parts of our consciousness that are typically are less accessible to conscious awareness. And in his paper, he's referring to these things as primary consciousness, which is always driving in our experience. It can also be thought of our implicit reality, all of the things, sort of the iceberg under the water that's informing how we're showing up to the present moment, moment to moment, really. All of our preconceived ideas, our notions, our cognitive and perceptual biases, and how we're feeling inside that we may or may not be aware of. And so that model is harnessing that. And other third wave behavior therapies have been proposed to be potentially beneficial with psychedelics through my colleague Zach Walsh. He's with UBC Okanagan and has written a lot in the field. And has a great paper outlining some of the rationale, theoretical and mechanistic rationale for these very much mindfulness-oriented, process-based types of therapy. Let's talk a bit more, but that's kind of an overview of what's happening right now. There's more to come as we'll see more and more studies rolling out for different indications. It's kind of an overview of the types and modalities of psychotherapy being combined with psychedelic adjuncts. So some of the mechanisms then, and this is where I feel like it's quite fascinating. You can see the picture on the upper right. You may have seen this already. It's a pretty popular depiction of the circle on the left, depicting our normal ordinary state of consciousness, where we've got very well rehearsed, typical functional connections in our brain, are very well rehearsed and conditioned patterns of thinking, reacting, and attending. Whereas the bubble or the circle on the right shows the number of connections happening and the increased repertoire of connections that happens when under the acute effects of psilocybin, a classical psychedelic. And this could be definitely applied across the board with psychedelics, that there's this increased functional connectivity that happens, new connections that can happen, and an increase in neuroplasticity, and something that Brower and Carhart-Harris have called pivotal mental states, which they're arguing in a paper that I've referenced here, actually an evolutionary advantage of humans, and part of what can be harnessed through when in moments of evolutionary pressure, but can be unlocked through the use of psychedelics that act on 5-HT2A receptors. Carhart-Harris is probably the world's foremost neuroscientist in psychedelics, so he's published a lot. He wrote a paper on the entropic brain, and then later a paper on what's called the rebus model, or the relaxed beliefs under psychedelics model, which is using the entropic brain theory that he previously outlined to sort of speak to the fact that in our ordinary state of consciousness, we've got all of these conditioned priors. And when those are relaxed with the presence of a psychedelic, all of a sudden, there's this bottom-up processing access. And this is actually depicted in the lower picture. So the top picture there is with the big arrow on top is all of these sort of top-down priors that are very conditioned, often rigidly wired, And then when you add something, that the little picture on the side is like a little ball dropping, it can kind of bounce off because things are so fixed in their typical patterns. And then when you add the psychedelic, all of a sudden there's this balance and this kind of harmony between relaxed priors and then this increased access to other areas of the brain and processing. And then things become more pliable. And so when this ball drops, it lands and kind of goes in, and then there's these ripple effects across the system and across networks. And so this sort of psychobiological mechanism that's, this is all drawn from functional magnetic resonance imaging studies of the brain under psychedelics, as well as observations of individuals and how they're doing pre and post. They very much support the psychological flexibility model and sort of approaches that are going to support and enhance what's happening here with these relaxed beliefs, relaxed conditioned priors, openness to new possibilities. And psychopathology is typified by rigid, like fixation. So psychological inflexibility. So a lack of openness, a tend to kind of revert to conditioned ways of responding and reacting in the moment, less openness or tolerance to discomfort, less awareness of other alternatives, stereotyped behaviors. This typifies things like major depression, ruminative states, aspects of post-traumatic stress. So, and really across the board, psychopathology and psychological flexibility models like ACT have been shown to have transdiagnostic relevance just as a psychotherapy. And what we're seeing is there's also likely transdiagnostic relevance of the psychobiological mechanisms of psychedelics. And so when you combine those things, it's actually quite exciting because we start to have a much more transdiagnostic understanding of psychopathology and potentials for healing that may be kind of coming down to deeper, more common factors. Another proposed mechanism from MDMA research is fear extinction and memory reconsolidation, which we know that with MDMA-assisted psychotherapy, there's attenuated amygdala firing and sort of a decoupling or decreased functional connectivity between the insula, which registers interoception and embodied states, and the amygdala, which is like our fire alarm, our smoke detector for threat, which is often upregulated in psychopathology, especially PTSD. And then there's increased coupling or increased connectivity between the amygdala and the hippocampus, which is where we are processing and storing and working with memory. And this in combination with the increase in monoamines, which has, this dynamic effect, seems to promote fear extinction and memory reconsolidation. There's other ways that, subjectively participants feel way less valence on negative states and way increased valence for positive states like self-compassion, empathy, trust, the ability to sort of revisit what would be otherwise excruciatingly painful to revisit in therapy when the support of the adjunct of MDMA is there. And again, this homeostatic autonomic regulation that was proposed by Sajaravzi as well, just sort of access to the natural inborn ways that our autonomic nervous system has to regulate itself, which we can observe in mammals and in other animal kingdom relatives. But that in humans, we tend to, when we have trauma especially, we tend to have mechanisms, top-down mechanisms that halt that natural discharge and regulation in the nervous system. A very common example is like two dogs are fighting, you break them up and then they vibrate for 10 minutes and then they just go on with their business kind of thing. And we too, we're mammals too, we need to discharge and move energies out of our nervous system and have survival completions. And it seems that the presence of psychedelics in the right therapeutic container and priming can really hold space for that, that type of process. So psychedelic therapy combines a plasticity enhancing drug action with nurturing conditions for the purpose of fostering a reset or recalibration of maladaptive habits of mind or behavior. This is one sort of statement. So it's really quite exciting. This is certainly not covering all potential mechanisms because we're still learning, but it's certainly many of the proposed mechanisms that are in the literature right now. And this is just Dr. Carthart Harris and the sort of the map of the connectome, or these functional connectivity networks. This picture is actually the default mode network, or midline structures that are very much affected in change in their functional connectivity under acute state with psychedelics. So this is also, I thought, just a really descriptive image here, where we've got acute state in the brain with psychedelics, increased neuroplasticity, increased entropic activity of the brain, behavioral acute state, so increased learning, reversal learning, extinction learning, relaxed priors, and then changes acutely in the mind, subjective psychedelic effects that are happening, which then we move forward into longer term changes where we see increases in psychological flexibility, cognitive flexibility, and mindfulness. And when you look at each of those alone in literature, aside from psychedelics, they're all associated with positive outcomes in mental health, with health behavior change, positive health behavior change. And so, this model is informed by evidence from the literature so far, this diagram, I should say. So it is really quite interesting to be mapping how these might be working and how they might be effective beyond the conditions they're currently being investigated for. This is just another slide just talking about how there's drug-induced changes that we've talked about. And then there's also something that isn't talked about a lot. I'm currently writing a paper about it, embodied intersubjective learning. So a lot of these mechanistic models of understanding on the previous slides are more intrapsychic or intrapersonal, but less speaking to what happens between a therapist and a client, or therapists and a client in that relational space I was talking about, which actually we know has a lot to do with brain development through childhood, and also just human learning and attachment. So things like co-regulation of the nervous system, corrective attachment experiences, attuned serve and return reactions with many people with psychopathology, PTSD. We're learning, with adverse childhood experiences, literature and whatnot, have really been missing through developmental periods. And psychedelics can really unlock, I believe, this potential to really use that neuroplasticity and that acute state environment to provide new experiences and new learning that are corrective to what was missing earlier on. We have neuroplasticity. Our brains can change at any point in our lives. Feeling felt, having rupture and repair, learning to trust that, experiencing safe touch, boundary repair when there's been past boundary violations, and other aspects of somatic trauma resolution. That combined with the effects of medicine, I think is very potent as part of the mechanisms of the outcomes that we're seeing, especially when applied intentionally. So we're almost there. I've been talking for 42 minutes. I'm going to stop soon so that we have time for Q&A and breakout groups. I wanted to touch, though, on some of the important competencies of therapists in psychedelic therapy. So this was outlined in a nice paper by Jan Phelps, who's the director of the California Institute of Integral Studies program in psychedelic therapy and research, which I'm a part of. And she outlined these 6 essential competencies of empathic, abiding presence, which has to do with mindfulness, equanimity, the ability to be present, have calm, sort of evenly suspended attention as a therapist holding space for someone who's experiencing altered states of consciousness, and often wide, big emotional charge, and a lot of charge and increased arousal states in the nervous system, for example, but to be able to be present and open to that as a therapist without going along on the ride so much, but being able to attune with it without getting thrown off oneself. And I would add to that a strongly developed interoceptive capacity, that's the capacity for an embodied self-awareness and strong regulated embodiment. So knowing one's own nervous system, knowing how to stay regulated in your nervous system so that you can show up through co-regulation to a person in an altered state of consciousness is extremely important for this competency. Trust enhancement, spiritual intelligence, which is sort of an awareness through personal experience of unitive states of consciousness, boundless love, things that we can talk about conceptually, but really when we've had experiences of them ourselves, whether through psychedelic experiences or any other type of experience, near-death experiences, experiencing life. We can develop this sort of construct of spiritual intelligence to be able to hold space without bias or influence for someone else to be having their own spiritual experience and making meaning out of that themselves. Knowledge of the effects of psychedelics is important. I think it's important to think about therapists having regulated psychedelic experiences to know or have some sense of what might arise or what one might go through when they're the participant or client. That's still under debate, and we're still working with regulating bodies to create pathways for that for therapists in training. Therapist self-awareness and ethical integrity is of utmost importance. Ethical integrity is of utmost importance in healthcare in general, right? There's always power dynamics. Doctors, therapists, psychedelics aside, are in positions of power. People are vulnerable. There can be abuses of power. We've seen that. That's why we have ethical frameworks now and much more severe consequences when there are transgressions and boundary violations and all of that, abuses of authority, but especially important when someone is in a wide open state of consciousness. I think an important safeguard in the application of psychedelic therapies as they are rolled out is to have closed loop secure video capture of what happens in a session that becomes a part of that person's medical record, because if ever someone has a different memory of what happened and they were in an altered state of consciousness, there's video record of what did transpire, for safety of both therapist and the client or participant. And then finally, this proficiency in complementary techniques there's a number of complementary techniques that Dr. Phelps lays out, but I would add almost a seventh. She's added this under 6 is implicit relational processing, trauma resolution skills, and understanding as well as human attachment and relational template formation as very important, because all of this is bound to come up when people are in these wide open states of consciousness. And we need therapists that are competent to work within those frames for the benefit of the person. So finally, last slide, what will the future hold? Well, potentially cost savings. I mean, I would argue that if these interventions are taken up and funded by our healthcare system, the MAPS data has shown already, based on QALYs and computational models of the cost of long-term severe PTSD and disability versus curative treatment, that the costs are recovered and there's cost savings within a 3-year period. So they're predicting that health insurers in the US will likely cover MDMA assisted psychotherapy, as it's recognized that this will very likely lead to cost savings. And, we already know that psychotherapy alone can lead to cost savings. We haven't yet seen psychotherapy, psychedelics aside, adopted into our healthcare system. There's a lot of changes that do need to happen, but I'm hoping that, especially with this kind of paradigm shift and the pressures in the system right now, that we'll just have a lot more attention on mental health and bringing that to parity and recognizing that's going to help us save money overall in our healthcare system and help improve quality of life, reduce doctor visits, etc. Other paradigm shifts, this transdiagnostic understanding of mental illness, a preventive approach, health behavior change, the potential of psychedelic therapies, actually sort of further back when we start to go back on the illness wellness kind of continuum from severe mental health conditions to maybe early intervention and prevention and getting people back on track without the need for costly long-term pharmacotherapy, for example. And also this notion of mind-body inseparability. You're like really recovering from the last several centuries, or I don't know, 600 years or so since Rene Descartes and this Cartesian mind-body split, and this sort of idea that I believe is perpetuated by the emphasis on physical disease by our healthcare system, and sort of this mind over body and body as object sort of lens that we kind of take implicitly. Whereas moving to an understanding of the absolute inseparability of mind and body, that they're co-influencing and actually one and the same moment to moment to moment, and that there's an intelligence to the body. And also actually the last bullet point there, the individual as a source of healing versus primarily seeing individuals as sort of walking pathologies, and the source of healing being external to them in our dominant paradigm. And really I see this as a very empowering shift for people that I think can help with motivation for change and more engagement in one's health. I think we'll see more applications of psychedelic assisted therapy. As mentioned, I'm working on a pilot study for fibromyalgia. My primary practice focus at Change Pain Clinic here in Vancouver is in chronic pain. And I have no doubt that MDMA assisted psychotherapy is going to be beneficial in chronic pain. That's my hypothesis, so we'll see, but I'm excited to investigate that, as well as other conditions that are very stress related, which is most conditions. There's going to be a bottleneck of therapist availability and competency. So this is a problem that we need to look at and talk about and solution around. There's also questions around the impact of corporatization and psychedelic finance and the way that companies like the one I contract with, Numinous, are sort of jumping into this space. I'm aligning because I think, capital markets is one way to translate research into clinical application much faster than the usual 20 years it takes. It takes money. And so, I'm jumping in to try and do that in a good way. But it'll be interesting to see what happens in this sort of corporate space with psychedelics. Also with the decriminalization, legalization movements, how much longer Health Canada will keep psychedelics like psilocybin and MDMA off the special access program, which is actually an infringement of the Declaration of Helsinki and is totally ethically wrong. They were taken off in 2013 by the Conservative government and not placed back on. Could talk about that more in Q&A. And then also there's a sort of surge in the field around artificial intelligence and integration of technologies. And when I start to read about that, I get a little like, hold on here, like this is going too fast, but it's certainly a field of inquiry that people are pursuing. So we'll see. So lots of questions, and there's probably more than there are on this slide, but I'm going to end there. Here are, these are the references that I've cited in this presentation. Happy to share this presentation, but if you do use it and if you reuse it, please do cite the original source. And to stay in touch, you can find out more about me at my website, drdevonchristie.com, the Psychedelic website, if you're interested in looking at the training offerings that I have with my partner, Ailey Jolie, who's a clinical counselor here in the photo with me. You can follow me on Instagram and Facebook, and I do respond to direct messages. And let's move into questions. Thanks so much for your attention. We'll stop my screen share now, or I guess you're going into breakout rooms. So there we go.
Hi, Devon. Thank you so much. Wow, there's so much information, and yeah, I feel we could sit here and probably listen to you most of this evening. In the interest of time, and because I do feel like you have a lot to share, we're actually going to skip our breakout rooms and go straight to Q&A for this evening. Yeah, that way we can get rolling with that. And I see some people have already started popping questions in the chat. And just a reminder for everyone who is online here, just type out your question in the chat and I'll pass them on to Devon here. And so, Devon, the first question that we have is, are there any studies you're aware of that compare standard therapy, for example, SSRI with CBT, to psychedelics with psychotherapy?
So for depression, Dr. Carhart Harris published a paper, I can't remember which journal, I'm sorry, I didn't cite it in this presentation, comparing psilocybin assisted therapy with a standard SSRI treatment for depression. And there was the result of that study did show advantage of the psilocybin assisted therapy over standard treatment. That's one study that I know of where there was a direct comparison. It wasn't super well powered. I mean, these studies are very expensive to do, but I think it was certainly an initial study with that intent. In the MDMA assisted psychotherapy trial, the therapy is the placebo arm. So they're getting, the people in the therapy groups with the MDMA study actually do quite well. They do better than Paxil and better than sertraline which are the sort of FDA approved treatments for PTSD pharmacotherapy wise, much better just with the psychotherapy. I think the effect size of the FDA approved SSRIs for PTSD is somewhere in the range of, I think, 0.3, which is like low to low moderate, whereas the effect size of the MDMA therapy with placebo is in the range of 0.9, much higher. And then when you get to MDMA assisted psychotherapy, the effect size is something like 2.1. It's extremely high. That's why it's been called a breakthrough treatment. So we are, these studies are using active placebos or standard psychotherapy, at least the one that's gone the furthest, which is MDMA. So those are the two sort of examples that I have. And I hope that we'll see more head-to-head comparisons as the research evolves.
Thank you. Next is any considerations or evidence you know of in unique populations. And the example was autism spectrum.
Well, there was a pilot study done with MDMA assisted psychotherapy in autism spectrum. I believe it was Alison Fiducia, author there. And oh no, I might be wrong, sorry, but it was, you can look for it because it is published. That the basis for that study was actually through online sort of chat boards for people with autism spectrum, expressing their recreational experiences with street ecstasy, which is, often contains MDMA, can contain other things, but that they were noticing changes in their social engagement, quality of life. And so that prompted this pilot study to look at MDMA assisted psychotherapy for social anxiety in people in autism spectrum. And there were positive results in that pilot.
Thank you. Next, we're having lots coming in here. Is there a way to refer patients to practitioners that are covered by MSP or other government plans? Or is this still in the research private sector only? And yeah, so essentially the question is, can we refer our patients? How do we do that?
Yeah. Well, so for the substances that are currently still illegal, MDMA, psilocybin, others, but those would be the primary ones. It is still absolutely within the domain of research. We hope that the special access program will open up in the next 6 months. Health Canada signaled last fall that they would move to reopen special access to psilocybin and MDMA. But even when they do, clinics, spaces that are set up to safely hold this type of intervention, it's going to still be at the cost of the patient. It's not known whether third-party insurance will cover it. Certainly, we've seen no indication that public healthcare is going to pick this up. The work I'm doing with Numinous, our long-term goal is absolutely to be lobbying for public coverage to really bring the stigma away and recognize that to consider these as psychological surgeries, right? So the cost of MDMA assisted psychotherapy start to finish could be somewhere around $10,000. You've got 2 therapists, specialized rooms, music, other aspects that are important, and about 42 hours of therapy with 2 therapists start to finish. So it's expensive, but I like to use the analogy of routine surgeries performed in hospitals every day, like you go in for a gallbladder surgery or something. If you add up all the costs of all the pre and the post and the OR time and the hospital time, and if there's complications and everything, it adds up to about the same just to get your gallbladder out, right? So, and we don't bat an eyelash at that because it's been part of our system. It's a physical ailment, physical cure. It's not stigmatized the way mental health conditions are. So we really need to shift our frame and recognize that yes, these treatments are expensive, but when you look at cost-benefit analysis, the reduction in suffering that they potentially may have, I think it really, I personally feel that it is worth it, and we should think about it differently. So right now, no coverage. Ketamine-assisted psychotherapy is the only form of, well, other than cannabis, but the only form of psychedelic-assisted psychotherapy that is currently available in Canada. And if you want to refer to that, there's companies like Field Trip Health, Numinous, and probably we'll see others opening up soon, it's going to be private pay, unfortunately. But we hope to see that change. Because the people that need it most are the ones that really can't afford it often. And so we really hope to partner with organizations, Veterans Affairs, first responders organizations, try to access pockets of money to at least get some people these treatments while we're waiting for public adoption.
Hear ye on all of that. Yeah. Mm-hmm. Psychological surgery, I like it. That's a perfect analogy. Next is any harms associated with this therapy. And the person was thinking about stories in high school about people having a, bad trip or having gone crazy after doing psychedelics. Is there any true medical correlation here?
Yeah, I mean, I think every powerful drug or procedure, has potential negative side effects, right? If we do informed consent with patients for things all the time, going in for surgery, you could die, right? So with psychedelics specifically, it's actually been, certainly there are transient sort of negative effects that people might experience in the acute phase. So like nausea, agitation, fear, this notion of a bad trip in the recreational context. In a therapeutic frame, there is no such thing as a bad trip because you have trained therapists that are there. And what is typically called a bad trip recreationally from a therapeutic lens is actually repressed emotional content, past traumatic memories surfacing implicitly. It may not have a story attached, but it's feelings of shame, feelings of overwhelm, feelings of fear, which is coming up and can be worked with and processed therapeutically. So that's actually not seen as a problem in a therapeutic frame, whereas in a recreational frame, it is and it can be. People going crazy, there's hallucinogen HPPD, I can't remember the acronym, but this sort of notion that like flashbacks of LSD trips, they've been named as a phenomenon, but not really well reported in the literature as sort of a potential negative outcome, although some people who experience them have framed them as positive. But a lot of that sort of going crazy kind of stuff comes very much from the war on drugs and the criminalization and the propaganda that was spread and stories that were actually not true that were spread. And I didn't include a slide on kind of safety and population level safety, but there's a lot of really compelling data on the safety of these substances, even when used recreationally, and then much more so, we might presume, in a medical context, in a controlled therapeutic setting. So with the MDMA studies, a common question is, do people go in to abuse MDMA afterwards? No. 8 people out of 108 in phase 3 reported use of MDMA after in sort of the years after the study, but it was actually used with an intentionally and not abused or not with negative consequences that when we see people relating to substances as escape mechanisms or in a addictive type context where there are harms to self, to others. So yeah, I mean, I could talk more about it, but I know we have more questions. But by and large, people wonder about suicidality increasing. There was transient suicidality or suicidal ideation in the MDMA studies that was resolved, not an issue, sort of with very few participants actually, and I think actually only in the placebo arm. These types of things. But the phase 3 data is published in the journal Nature Medicine. It was published a few months ago, the most prestigious journal. It's pretty exciting because MDMA-assisted therapy has been funded by donors. It's like one of the few drugs that's actually going for full FDA approval, which is multi-million-dollar process that's not been funded by a big drug company. So I feel so inspired by the people that have been leading the charge and joining the charge, in that. And yeah, the safety data is quite compelling.
Beautiful, thank you. Next up, what are the typical populations involved in the comparative studies? Example, are they first presentation MDD or only refractory to treatment? And I think it would be interesting as well just to hear, the typical demographic.
Yeah. So in the comparison studies, like the one I was mentioning before, or are we talking just in psychedelic studies in general?
I'm not sure. Kate,
I think I can speak a little more just in general. As I mentioned at the beginning, there's absolutely this bias in the research towards white cisgendered heterosexual research participants. So there's been a lack of representation of racialized or minority groups, Black, Indigenous people of color, people of different gender orientations, trans-oriented, non-binary folks have not been well represented. In terms of presenting pathology, the research with psilocybin that I'm aware of is in treating treatment-resistant depression. That was the breakthrough indication, and major depressive disorder was a second breakthrough indication. So there were two breakthrough indications granted by the FDA for two different sort of study groups. One was led by Compass Pathways. But for the most part, I think what we've seen in the psychedelic renaissance, sort of treating treatment refractory, severe PTSD, treatment-resistant depression, end of life anxiety and mood disorder, because of the difficulty in getting Section 56 exemptions and even access to study these drugs because they're still classified illegal substances, which under the classification that they're in, part of the definition is that they actually have no medical value. So, so we're trying to like get them moved to a different category of classification, but using the most extreme examples where there are no other options for folks. They've exhausted all their options and new treatments are needed. And that's been part of the way that these studies have gone through ethics approval and been allowed to proceed. So I think we'll see a widening now as it's easier to get ethics approval, maybe with special access program opening, different regulatory changes, maybe decriminalization, other things. I think we'll see studies that are looking not only as the most extreme resistant or refractory conditions, but a more broader spectrum of conditions. And I think that would be really good because I do see that, you know, to intervene sooner for people is going to save a lot of suffering and cost and improve quality of life.
Mm-hmm. Thank you. Could you comment on the rough time frame you might imagine psychedelic assisted psychotherapy will actually be incorporated into routine clinical practice? So, you know, how far away might we be from seeing this? And then there's a second part I'll ask actually after.
Sure. Routine clinical practice, I think we're a ways off. You know, seeing it in clinical practice at all. We're there with ketamine-assisted psychotherapy. It's happening now in Canada, which is a departure from the medicalized intravenous ketamine model. Just to note that, right? Again, this is psychedelic as adjunct to a psychotherapeutic process versus just the effects of the drug and harnessing more than the sum of their parts, like my talk is talking about. MDMA, I think we'll see FDA approval, we expect, by the end of 2022 or possibly early 2023 when the second phase 3 studies are complete. And so that's exciting. And there's sort of reciprocal agreements. You know, Health Canada would then move to approve that here. Once it's approved, we'll see it in clinical practice, but I don't think it's going to be routine clinical practice. My hope is that we might see these things entering routine clinical practice in 5 to 10 years. And again, there's the bottleneck of therapist training, you know, the technical aspects of setting up these interventions. It's like setting up an operating room, right? You have the screening, you have an anesthesiologist who's like, you know, doing all of that. And then you have like the OR room, which has all the specialized stuff to actually do the thing, which in psychedelic therapy, you need rooms that are ideally soundproofed, have really good sound systems and a whole, you know, environment. And then, you know, post-op, there's a lot involved there that doesn't lend itself to scalability very well. Yeah, it just requires a lot of infrastructure. So, but we shall see. But we have ketamine-assisted therapy now. MDMA, I think soon. Certainly there's been some Section 56 exemptions for folks with depression and end of life anxiety with psilocybin through the great work of Theracil. I noticed somebody on here has done some training with Theracil. I saw that pop up. And so some of those folks have been treated, but again, Health Canada has actually really shut down and closed the door on their Section 56 exemption process. They've been inundated. And of course, now then we've been through an election and appointment of a new cabinet. So there's been a bit of a lull and pause. But I hope, the Liberal government was signaling positively to move ahead. So I hope that we'll see that continue.
And that's a perfect segue into the second part of this question, was thoughts about some of the legal barriers that do exist given these substances are scheduled, and do you envision these laws changing anytime soon?
Yeah, I mean, it's such a different thing, right? Kind of application of psychedelic assisted psychotherapy within a healthcare model versus, decriminalization, legalization, opening up recreational use, which I also, support. I mean, I think decriminalization is important just, from an epidemiological perspective for the well-being of society and, the fentanyl crisis and everything else that we have going on. Access to safe drug supply is an imperative, I think, for population health, as well proven. I mean, I'm not an expert in that, so I can't comment too much on where that's going. There's certainly a lot of petitioning of governments and local governments to, decriminalize or stop policing, possession of plant medicines, for example. We've had movements here in Vancouver. We've seen them in other places across North America, Oregon, for example, and California and districts. So, but from the sort of medical side, I think we need to see these substances taken off of the schedule that they're currently on, that is utmost restrictive, illegal, and put into a schedule where medical use and health benefit is part of their classification, so that it can be accessed through regulated channels with safeguards, and be prescribed and used, and not have all these requirements for exemptions and all of this to be done through the federal government. So how far away are we from that? I don't know. I hope to see it happen soon. I mean, at the very least, like I say, the special access program, having those substances placed back on is step one, really, to at least not be ethically infringing the rights of people who have gone through clinical trials and access something life-saving, and then they're exiting the trial and can't access it anymore. So think about cancer, chemotherapy drugs. Special access program is there for continued access to that before that drug is officially approved. And so too, it ought to be for these substances where we're seeing these very legitimate randomized controlled high level studies being published with these substances. Yeah, so I think it's hard to speculate, but hopefully with increased pressure and also increased awareness, especially within the profession, among colleagues too, to understand and really start to destigmatize and understand how these might be beneficial, and just understanding them as tools and within a healthcare context for well-being, I think will help groups like us to also be lobby groups that are pressuring for change, which I think is really important. Physicians have a strong voice at the table in policy change. So I would love to see us organize more. And there are pockets of colleagues that are specifically working with the college too, because even the college is also around ketamine. There's been a lot of back and forth, so to speak. So yeah, I just hope it'll move ahead swiftly.
Indeed. Do you think with proper training, this could be a family medicine-led therapy, or, who will be doing this? Psychology, psychiatry, a team? And for people who are interested, suggestions on where to start with training?
Okay, that's a great question. Certainly it's an interdisciplinary model, obviously with, I think ideally medical and psychological or psychiatry screening at the outset, considering inclusion, exclusion criteria, et cetera. The intervention itself, there's differing opinions here. As a family physician, I did not consider myself equipped to be with a person psychotherapeutically with severe PTSD. I did not consider that I got enough training as a family doctor to do that competently and safely for someone, which is why I went and did a 2-year certification in trauma therapy and became a registered therapeutic counselor, which gave me much more background to step into a room and feel like I actually can, really skillfully meet a person experiencing those states in their body mind. That's what I did because I wanted to be an MDMA therapist and participate in all this research. Personally, I felt it was an important step. Now, there's a huge, force of people needed to do this work, but there's things that happen in a therapeutic container that we don't necessarily get exposure to or understanding in medical training, for example, such as countertransference, right? Transference and countertransference dynamics. What is that? Well, countertransference is when something that's happening in the client that they may be projecting on me, transference is triggering something in me, and then I am unawares and then projecting a whole bunch of stuff and reacting back onto them. My stuff, my unprocessed stuff that's getting triggered in the moment. When unaware of this, it can be very countertherapeutic, potentially even harmful in an ordinary setting, never mind when someone's in a wide open state of consciousness and all of that's getting put on them. So these are the types of things that I think about, or like when trauma comes up, like how to really meet that skillfully. These are the things I think about that are important skills that I think it behooves people to get, but this is the bottleneck problem to sit safely with people who in these expanded states of consciousness. So where to get training? It depends kind of what modality you're looking at and such, but there are like the California Institute for Integral Studies. They take people from medicine, from psychology, counseling, clergy members, ministers, a number of different backgrounds into their program. And it's a very robust program in psychedelic assisted therapy, but not so much a robust program in being a therapist. So there are places to get kind of training, so to speak, but I still personally feel that taking some sort of program in therapy modalities and getting proficiency there, and number one, actually being in therapy oneself, right? That's the most important thing, because you can only really navigate with people into these in psychedelic states, very deep states of anguish or shame or despair or death kind of, or like ecstatic states of bliss and everything, so much as we've kind of gone to those territories within ourselves and had our own dark night of the soul and really dug in and done the work of our own, trauma resolution and even identifying that it's there. It's very common in physicians. Physicians have a lot of ACEs, particularly a lot of developmental trauma that leads to complexes like achiever complexes, perfectionism, and this type of thing that are protectors, and they're there, but if we don't examine these things but then want to show up and do this deep type of therapy work with people, I just think there's a bit of a mismatch that might ultimately, at the best end of this scenario, be just like somewhat countertherapeutic, and at the worst end of the spectrum, harmful.
Ooh, I feel like that could be a whole lecture in and of itself.
Yeah.
Thank you. Just a few minutes left with you here. Our next one is, do you use elements of medicine wheel in these sessions? So fire, water, air, earth. And secondly, how do you advise patients who would want to continue use of psychedelics on their own after therapy sessions?
Okay, so medicine wheel, I've been privileged to learn from an indigenous elder of the Siksika tradition, Blackfeet people. He's taught me his medicine wheel. I have permission to share that medicine wheel. Medicine wheels are different depending on different indigenous, they have different permutations. Not all indigenous cultures have them. But just as, but more medicine wheel aside, which I think is a beautiful model of holistic wellness and everything, just the elements, irrespective of a medicine wheel, certainly can be used. And actually in internal family systems, there's a process called unburdening. So in internal family systems, we have parts, we have exiled parts, we have protector parts, they're all part of us. And protectors are there so that we don't tap into what the exiles are holding, because they're usually holding anguish, pain, all kinds of stuff that our psyche doesn't want bleeding into our experience, because it's just awful. And at the time it happened, it was just overwhelming. So in the unburdening process of exiles, which happens in psychedelic therapy beautifully, psychedelic therapy takes protectors away in a way that's very profound. And part of in IFS unburdening, you can suggest elemental support. So like seeing that go up in flames and the smoke going somewhere and transforming, or bringing in the water element as a cleansing and renewal, or using the breath and the air element to like blow out all of this stuff that is, coming, being unburdened. So there's absolutely, I mean, that's one example from IFS, but I think there's like beautiful ways that elements can be invoked that can really be culturally sensitive, because elements are elements. And as long as we're not appropriating or in sort of ways, specific traditions from specific people without naming them or acknowledging where those teachings have come from. What was the second part of the question? Sorry.
Yeah, that's okay. Second part was, a separate question, but also very interesting. How would you advise patients who want to continue use of psychedelics on their after therapy session?
Yeah, so that's tricky. There's this sort of harm reduction approach with psychedelics, like even now, because of the explosion in the media, publications like Michael Pollan's book, How to Change Your Mind, and articles in the New Yorker and the Globe and Mail and the New York Times, and this is like all over the place right now, and people are desperate. So there's a whole move towards psychedelic harm reduction and integration, and even holding circles and spaces where healthcare providers can use a harm reduction lens and try to guide people towards reputable sources of information, et cetera, without necessarily recommending use oneself. A lot of people are microdosing, so using like small amounts of psilocybin, for example. They tend to find information on the internet about how to do that, where to do that, and that actually microdosing hasn't been studied much at all, so it's hard to even advise from an evidence-based perspective. There's been a few studies, but nothing of the rigor we're seeing in macrodosing studies. So it is tricky. I mean, personally, from a harm reduction perspective, I say, like, patients ask me because they maybe heard me talk or something, and I say, look, unfortunately right now, there are no really means through which I can make any recommendations that are going to be safe for you to be doing this outside of a regulated context. And so it's a little bit of a bind, I think, and that's why I'm doing this work so much, to actually help bring these things above the board and into regulated contexts as soon as possible so that people can access them. But I generally just say, look, there's a lot of perils. There are many underground therapists, some of them wonderful and some of them dangerous. And how does someone know the difference? And because it's underground, so it's hard.
Yeah, indeed. All right, we are 8:29 here, so I think we'll wrap it up. I know there are a few other questions there, but yeah, thank you so very much, Devon, Dr. Christie. It was an absolute delight to have you here with us, and just the wealth of knowledge that you shared with us. So thank you very much. Much gratitude for that.
Thanks.
Yeah,
it's a pleasure. And thank you for organizing this and helping to spread awareness among our colleagues of these emerging therapies. I think it's really important. So thank you.
Yeah, we're really excited to be doing this. And yeah, just to let everyone know, we'll be meeting again November 10th, so next month, and that will be with Crosby Walter, and he'll be speaking with us about the failed promise of modern psychiatry. And so an invite similar to this one will come out, and we'll hope to see many of you all there. And just a friendly reminder as well to everyone who's here to please complete the evaluation, and I'll ask Antoinette to just pop that into the chat again here. And I saw the link was posted earlier as well, where people can find the talks and recordings from previous presentations. And yeah, lastly, again, just thank you so much, Dr. Christie, and to everyone who attended, and take very good care. Bye for now.
Good night.